Well, good morning, everyone. Thank you so much for joining us here today. My name is Ricardo Batista Leite. I am the founder and president of the Unite Parliamentarians Network for Global Health. For those who are not familiar, Unite is a global nonprofit bringing together members of parliaments, congresses, and senates from 120 countries around the world together to promote science-based policymaking in the field of health to ensure that legislators are working towards ensuring health for all. And today, with more than 500 members of current and former legislators from across the planet, we have had the privilege from very early on in our existence as an organization to be working directly with the AIDS Healthcare Foundation, a long-standing partner with whom we are gathering here today with their support and partnership. And so we're very, very grateful. And this high-level roundtable will be discussing the topic of financing health equity and security. Very easy topics for us to solve here this morning. And so I'm going to call the speakers because we only have about an hour. I also want to open to the floor to open for questions. So get those brains of yours moving and preparing some questions for our panelists. And the first person I want to call is the chair of the board of the Parliamentary Network of the World Bank and IMF, member of Parliament of Luxembourg, my dear friend Sven Clement. Thank you so much for joining us. And also to say that we're very grateful for our long-standing partnership with the IMF World Bank Parliamentary Network. I was a vice chair myself many years ago, and it's a very important partnership for us. Of course, we all know Priya Basu, the Executive Director of the Pandemic Fund. Thank you so much for joining us. We also have Rosemary Buru, Executive Director of WASI Health. Thank you so much. Also a long-standing friend and partner of Unite, Mark Ligon, Chief Policy Officer of Friends of the Global Fight Against AIDS, TB, and Malaria. Thank you for joining us. I think you had the shortest commute of all speakers. And also, finally, my dear friend Kemi Hiro, Director of AHF, a Public Health Institute for Africa. Thank you, Kemi, for joining. So we want to discuss the topic of financing health equity and security. And this week, we've seen multiple reports coming out of the World Bank and the IMF showing that economic growth has basically stagnated or is moving in a negative direction. We know that multilateralism is currently in crisis. We know that there is lack of prioritization of health as governments right now are deviating funds to other areas, security, defense, and so forth. We see a retraction. Everybody focuses on the U.S. stepping away from their global responsibilities when it comes to global health in terms of international development funding. But in reality, many member states are lowering their contributions to this space. Philanthropy, I would say, has become the go-to place for many organizations who work in this space, but they cannot absorb the full shock of what needs to be responded to. And I would say the frameworks for private sector involvement are not mature enough yet to make sure that there is a full compensation and evolution towards true public-private partnerships. Although we do have some positive examples, and we will certainly be discussing about those. And I think I see Priya with the Pandemic Fund has been making tremendous strides in that matter. We know that the IMF World Bank spring meetings are supposed to present to us trajectories on how we're going to make certain fiscal decisions on to make sure that the resources are available and that investments can be made to ensure that we can address the issue of health equity globally, of health preparedness, if you will, and health security. But the dual crisis we're facing with the fiscal pressures, the sovereign debts, the cuts that I've mentioned, the competing priorities, but also the health insecurity from below, the pandemic risks, the weak systems, tackling non-communicable diseases, and so forth, is a major challenge. And so we depend on our leaders to find solutions and to guide us into a better place. But I would also say we also depend on civil society on stepping up and being an active voice to make sure that those in positions of power understand that we cannot leave those who need our support behind. And we always know in a time of crisis, it will be those in most vulnerable conditions that will be inevitably the ones that will be left behind. I've tried to frame this discussion, and we have some guiding questions, as always, in these panels. But before diving into those, I would like to give each of you an opportunity to provide a couple minutes of reflections based on your experience, from where you're coming from, on how yourselves and your organizations are looking at these challenges and potential paths forward. So, Sven, since you're running the World Bank and IMF, we can start with you.
It would be honestly, I wouldn't want to run both institutions. I have great respect for the leadership at both institutions because they have an even busier agenda than most of us. But in the end, when we look at ODA in general, and you mentioned it rightfully so, the UN reported 2 weeks ago that only 4 countries remain on track for 0.7% ODA spending in their budgets. So we all agreed, we all pledged that countries should spend 0.7% on ODA, and there are only 4 countries globally doing so. I think this should give us already a moment to pause and to rethink our priorities. At the same time, we have NATO countries now on track to spending 5% of GDP on defense. I would argue, sitting at that intersection, working on both topics, I would argue that spending for health is actually also something that should fall to a certain extent under the resilience spending, the 1.5% that we're currently looking at NATO. Because if you don't have a healthy population, you can't be resilient against external shocks. So first of all, we don't necessarily need to reprioritize, we just need to be very intelligent in how we account for different kinds of spending. This is something I want to leave with you as a first thought on how can we do more with less, or at least with the same amount of money. The second part we are looking at is obviously how can we increase targeted spending? Where do we get the most bang for a buck? Because if resources are scarce, we can't be going around and give money randomly to every project that comes around. We need to be very intelligent in how we spend it. I believe the times of countries building like those hospitals, single hospitals in a country, flagship projects, and saying, oh yeah, but we did great. And I count Luxembourg into that. So I just came back from Mongolia, where Luxembourg is now building the cardiology center of Mongolia together with the EBRD to make it possible for Mongolians to get healthcare on cardiac issues. But it's not building that flagship project that will solve the health crisis, the cardiology crisis in Mongolia. It will be getting more nurses, more practitioners into the field, in the rural areas, and building the pyramid from the bottom up. So if we are looking at healthcare spending, I think we can get a lot more bang for the buck if we spend on the lower levels of the pyramid, and then step by step building up the capacity into those flagship projects. And last but not least, if we are spending money that we should be spending also in other countries, because in the end, if we don't have a healthy population across the globe, we'll see a lot of issues coming up again and again. And I'm very happy that we'll be talking a bit about pandemics, I hope, because if we as the global north leave countries behind, we discount the potential for the next pandemic to arrive on our shores. So in the end, it's not simply philanthropy that we are doing by spending money on healthcare. It's also spending in our best interest making sure that the planet as a whole stays safe. So those three thoughts I wanted to start with. There's a lot more to say, but given the limited time, I'll stop here. Thank you.
Thank you, Sven. And so, Priya, this is a great segue. Pandemic, resilience investment, very much needed for economic development and security, very much down the lane of the pandemic fund. We'd like to hear your thoughts.
Thank you very much, and good morning, and it's great to be here. And I think, Sven, you've made a lot of good points. Ricardo, you framed this discussion very well. Maybe from where I sit, just a couple of thoughts that I want to share this morning. I mean, first of all, pandemic risk, if anything, it's exacerbated by climate change, by changing land use patterns, by urbanization, by changes in biodiversity. I think scientists predict that there's more than a 50% chance of another COVID-like pandemic hitting us in the next 20 to 25 years. So this is, it's a real risk, and it's growing. So, I think what we really need to keep front and center in a world where there are multiple crises and multiple challenges that the international community and governments, need to focus on. Let's not fall into a cycle of neglect followed by the panic of COVID-19, because, I think if there's one lesson that COVID taught us, it's that the cost of being unprepared are just tremendous in terms of lives lost, but also in terms of trillions of dollars of world GDP lost, hard-won gains in economic development being reversed, after COVID, I think, the smart calculus for any finance minister or any leader to make is, let's just, make those investments in preparedness now so that we can avert the costs of not being prepared. Against that backdrop, I would just say that, the lesson is that another lesson from COVID is that pandemics are not just health events. These are major risks to the global, to the stability and prosperity of the world, right? And that what's needed really is smart, disciplined investment in this very important area. Now, yes, there's a fiscal crisis in the world. ODA is stretched. So I think the question then is, first of all, let's invest smartly. Let's, when we think about health and when we think about pandemics, let's try to find a way to, find ways where, every dollar achieves maximum impact. And let's also remember that, some of these investments that we're talking about in pandemic preparedness, which is about sort of early detection, it's about surveillance, it's about diagnostics, it's about workforce. These are core to building resilient health systems. So they shouldn't be seen as some kind of silo that, some vertical silo that we're investing in. These kinds of activities are central to building strong and resilient health systems. And they not only allow for day-to-day delivery of routine healthcare, but if you invest smartly in these areas, they get you ready to deal with a crisis if that crisis does happen. And I think there, I would focus on very much also on prevention at source and thinking of ways to, investing in areas where you can quickly detect an outbreak before it spreads from animals to humans, so zoonotic outbreaks. And so, that is the most effective way, I believe, of protecting people around the world, and that's where the pandemic fund comes in. I think our strengths are really in our model. We are country-led, so first of all, we're not sitting here in DC kind of deciding, how countries should spend. We're asking, the 147 countries that are eligible, these are low and middle income countries that are eligible to receive funds from us, to prioritize, to look at their own national action plans for health security and decide, where the gaps are and where they want to spend. We're catalytic, which brings us to, the point about being in a world where resources are strained and stretched. So how do you maximize every dollar? How do you ensure that you stretch taxpayers' dollars to the maximum. And you were talking about this, Sven. So we are catalytic. So far, for every dollar of grants that we've awarded, we've managed to mobilize 7 additional dollars. And about 4 of those came from international partners. So we're able to mobilize from multilateral development banks and so on. But very importantly, 3 of that 7 came from the countries themselves, the low and middle income countries. So that leads me, that's also linked to my point about being country-led, because I think, the chances of aid being effective are much higher when countries take ownership and they put, their own skin in the game and they put their own investments, and that's how you can sustain those. And then we're efficient. We have a very, very low operating cost. So, and we take this One Health approach. So we take a multi-sectoral perspective to investments in pandemic prevention, preparedness, and response, recognizing that nexus between animal health, human health, and the environment. We are non-duplicative, so we're not actually, investing directly. We're using our grants to pull partners together from the public sector, from international organizations, from NGOs, from civil society, and so on. Bring them all together and provide a cohesive stream of funding. So we kind of foster collaboration, coordination, and avoid duplication. And we're already beginning to see some very good results. We're only 3.5 years old. We already have a portfolio of $11.5 billion in 128 countries. And I'd be happy to, later share a little bit of what our, early investments are producing, including actually in Mongolia. We have a very good example of how our investments have contributed to being able to quickly catch the anthrax outbreak last year in Mongolia. So thank you.
Thank you, Priya, for bringing some positivity into the discussion also. And it's great to see the way the Pandemic Fund is evolving. And I think you raised an important topic that connects well to Rosemary, which is the issue of how your model is based on a country-led principle. And Rosemary, you play a very important role across Africa on the advocacy side, but also here in the multilateral space, representing African interests. Do you feel that in this context, the African voices are truly being heard and leading the way? Is there a change that is happening? We heard about the Accra reset and so forth. In this whole context of the discussion we're having, we'd love to hear your initial thoughts.
Yeah. So thank you very much for that. I'll start by reflecting on the fact that around the world right now, we have about 4.5 billion people without access to essential health services. That's more than half of the world's population. Majority of those people are in Africa, Southeast Asia, and many other low and middle income countries. And that's data, that's where we stand right now, without even talking about a pandemic that could happen tomorrow, or the ongoing crisis and external threats. And so if you combine that lack of access, the inequity, with the possibilities of threats, whether it's pandemics, whether it's climate crisis and all that, those numbers will look much worse. And so I think that's the starting point, to just look at the inequity that exists around the world. And then we go to the Africa region and appreciate that this is a really difficult time in the context of global health, where we have seen shifting priorities around investments. And it has been mentioned right now in terms of 0.7% commitment, we are seeing that declining. And so we are also seeing greater desire for domestic leadership among African governments. There are a couple of policy frameworks, like we have the Africa Leadership Meeting on Investing in Health, which is the ALM framework, which you could say is Africa's blueprint for domestic financing. And it has a couple of targets. It has the old Abuja Declaration that many of us know about. It also has a commitment around 5% of GDP going into health. it also has quite a number of targets, but also it has a target around out-of-pocket expenditure, that it is important, and African governments looking towards reducing the amount of out-of-pocket expenditure to come to below 20% by 2030. So I think the first thing to say is that we understand the inequities and that you have billions of people without access to health services. We also appreciate that within the Africa region, we have the frameworks, health financing frameworks that lead, and support and guide African leadership around how to do better in terms of domestic investment. But I think that's also constrained by a number of factors, and maybe we'll hear more around that later, that the decision around the choice of what you invest in, whether it's in health or other infrastructure, it is also a very tough decision, because the fiscal space, as we are talking about, is a bit challenging. Many countries are still coming out of the impact of the pandemic. Many countries are still struggling with debts. Many countries in the region are also facing what we call high rate of access to capital. Like you have African countries, accessing credit for up to about 10% interest rate, while their counterparts in high income can access the same credit by around 2% of interest rate. And so there are all these factors. But as we continue with the conversation around sovereignty, which doesn't mean Africa being on its own, not being in our own little corner and moving things from there, but it's really about being more in control around the decisions we make, around the decisions that our countries make in terms of health. And perhaps the other reflection is, even as we go into, thinking about more sovereignty and how these partnerships can be more reinforcing, what we are seeing is that more now than ever, it's important to think about how robust accountability mechanisms can come to play, because we are seeing more and more the shrinking multilateral space and opportunities, and we are seeing more bilateral conversations that are also, sort of government to government, and therefore leaving out other stakeholders like civil society, like parliamentarians as well. And so I think there is an opportunity right now to say the world order has been disrupted, and because of that, we really need to think about how we come together as civil society, parliamentarians, to partner with our governments around stronger, robust mechanisms. And so even to Priya's point, to say it's country leadership, but then also defining that country leadership to say it's the whole of society. It's the government, development partners, civil society, communities all coming together. Thank you.
Thank you so much, and extremely important points there that we'll have to deep dive a bit into. But this last point on understanding how a shift towards bilateral engagement between governments has a tendency to leave out key relevant stakeholders from civil society and others is one of the pitfalls we might fall into a post-multilateral world. And it's one that clearly we're seeing several examples of that happening. And Mark, you've seen it all across the board. It would be interesting to hear your perspectives coming also from the U.S. context. Of course, we know the disruptions that some of the cuts that the U.S. administration have made in global health have been having. But actually, in the field that you've been working in, you've been able to be relatively successful in times of peril with the Global Fund. It would be interesting to hear your thoughts about everything we've discussed until now.
Well, in limited time, and of course us wanting to go to our audience participants, some high-level thoughts, and I admit biases. I'm with Friends of the Global Fight. We're advocates for the Global Fund, and we're in the U.S. I work in Washington. But I think there are four things that are complexities that are sometimes seen in overly simplistic terms. One, that the U.S. cuts in global health are radically larger than the cuts of other advanced industrial countries. But if you look at the Global Fund's replenishment last November, the Trump administration pledged $4.6 billion, but Germany and Japan cut by 50%. A co-host of the replenishment, the UK, with the Prime Minister announcing it without embarrassment, was a 30% cut. Secondly, that the U.S. and the Trump administration hate multilateral institutions. Well, not all. They think that there's something about the Global Fund and need a multi-stakeholder model that has some benefits. I think we're trapped in this debate that we perpetuate about vertical versus horizontal health. Some of the programs that have made enormous strides on AIDS, TB, and malaria contribute to larger health. And if you look at, for instance, the Global Fund's policies, it's invested in health system strengthening and pandemic preparedness. In fact, in recent months, it has had occasion to spend more on pandemic preparedness than the Young Pandemic Fund as itself. And then fourth, country leadership. The point I was going to make is exactly the point that Rosemary did, and I can't say it more articulately, but country leadership must define country as including civil society, not just governments. The government-to-government negotiations between the United States and other countries has the risk of leaving out civil society. I know this is something that, Priya's struggled with. There was a long effort to just get 2 seats on the governing board of the Pandemic Fund for Civil Society, and one of them is reserved for the Global North Civil Society. A couple thoughts just on finances, since Jen Cates couldn't join us today. Today, Friends of the Global Fight is releasing a report called Sustaining Progress Against AIDS, Tuberculosis, and Malaria as Countries Transition to Growing Self-Reliance. Its purpose is to urge the Congress to do oversight of the administration policy on the MOUs and the transition. Relative to the fiscal 2025 congressional budget justification, our report says, the bilateral agreements with countries around amount to about a 1/3 decrease in total 5-year U.S. spending. In many countries, the U.S. will no longer be doing core global health work, maternal and child health, family planning, non-communicable diseases. They're barely in the MOUs negotiated with African and other countries at all. Many countries that had bilateral malaria and TB programs funded by the U.S. will not. Social interventions and education are falling away in favor of commodities and clinical services in U.S. aid. Those countries that don't have MOUs or even have been bold in refusing them face disasters. South Africa, Tanzania, Zimbabwe, and Zambia. And finally, those countries that have agreed to the MOUs have co-financing targets that may not be feasible. And we have to get beyond this large term of fiscal space to a practical situation where health ministers are actually working to devote funding to this. And that is the job of, I think, of members of Parliament to really press those finance ministers.
Well, thanks, Mark. And you've highlighted the issue of the fiscal space, which is incredibly important. Kemi, AHF, of course, has very strong positions on how cutting-edge medicines and advocacy must reach people independently of their ability to pay. But we know that the fiscal space, especially with the sovereign debt crisis, is being crunched. It would be interesting in this context to hear your views on this.
Thank you very much, Ricardo, and hello, everyone. Yeah, I think when we talk about financing health equity and security, it's impossible to talk about that without addressing the sovereign debt crisis. And the reality is I don't think we are as agitated as we should be over the crushing debt crisis, because more than half of the world population, and that's about 3.3 billion people, actually live in a country where more is spent on servicing debt than it's spent on health and education combined. And that is a problem. And what that means is that countries are being forced to choose between paying creditors and keeping their citizens alive. That is the severity of the situation we're in. And why we believe in country ownership, we believe that countries should take leadership, that domestic resource mobilization is important. It is almost impossible to do that if interest rates are rising every year, but yet the per capita on spending for health in low-income countries still stands at $17 annually. There's not much you can do with $17. And actually, the minimum package is about $60 in terms of health care. But yet, you see that they're rising interest rates, but then you still have countries at $17 per capita. Now, the reality is, when we talk about financing, we must also interrogate the financial architecture, the global debt system, because there are inequities that lie with it. For example, Rosemary mentioned earlier about how poorer nations or developing nations have to pay more in terms of interest rates than wealthy nations. They pay about 2 to 10 times more than a wealthy nation. That in itself is already inequitable. Number two, the rules are outdated. Some of the rules that we use, when it comes to the global debt system, in terms of the credit ratings that are made, who decides that a country is less creditworthy? What is the yardstick for that? It's basically saying that because you're from a developing country, then you're at a higher risk of default. So it's about going back in terms of reforming the financial architecture. Because if countries have to spend so much more on debt servicing than they are spending on health or education or on basic social protection measures, then we're leaving countries farther and farther behind when it comes to the issue of health equity. And this is something that I also think that even with members of parliament, there is a role to play. But even as AHF, and it's something that we're working on now as an organization, is around the Freedom from Debt campaign. And it's not saying that countries should not pay back debt. It is saying that while debt is supposed to be a tool, sovereign debt is supposed to be a tool for development, the rules that guard it are extractionary in itself. And that makes it difficult. So rather than helping countries advance, because if you're caught in a cycle, it is a vicious cycle, where every year governments are spending more on debt servicing, spending more on high interest rates. Just in 2024 alone, over $921 million went into debt servicing. Interest rates. So that also begs the question in terms of what are we doing about the debt crisis? There have been recommendations that have been made, either from the Seville Financing for Development Summit or the G20 in terms of, for example, having a borrowers forum. Because what we see is that private creditors, for example, hold more than 60% of debt. And a number of these private creditors are not regulated. So it is asking and pushing for things such as the borrowers forum, which was one of the recommendations that came out. And that is to say, if you have a borrowers forum, it has, it's been established, but it needs to be more functional and operationalized. And what that does for countries is that it helps to increase the bargaining power, the negotiation power that they have even with creditors. But beyond that, it's providing them the technical expertise when it comes to debt management, the ability for peer learning and sharing. So that's one thing that I think the world needs to move really quickly on when it comes to the borrowers forum. Number two is countries shouldn't have to pay or shouldn't be servicing debt when they are faced with a public health emergency or crisis or a climate disaster. And so the whole conversation about debt pauses and, and for that to be standardized across the board. We know that, yes, the World Bank, the IMF is beginning to do that, but it's not the same when it comes to the private creditors. So being able to standardize the fact that countries should not have to pay back debt, at least they should be able to have interest-free whenever they are faced with a crisis, whenever there is a public health emergency that has been triggered. countries should actually be able to focus on addressing that. Because if we say the physical space is constrained as we all know it, and rising debt, sovereign debt makes that even worse. But another thing is, I think when we look at financing health equity, because the more we do not address the crisis that we're seeing with debt, we would leave countries behind. And we're seeing that. We're seeing that because it's the difference between having to pay an exorbitant interest rate as against having a hospital in a community. It has implications in terms of universal access to healthcare. It has implications in terms of infrastructure for health. It does have implications even for workforce at the end of the day when it comes to human capital for health. So that's why for us as an organization, we're also thinking of other innovative ways. We talk about sin taxes. We talk about DRM, public-private partnerships. But we also think that there is a sector that we're not looking at when we talk about financing, and that is the artificial intelligence sector. It is a heavy wealth generating sector. It is actually projected that between now and 2033, the AI market is going to rise from $189 billion to over $480 trillion. What are we doing in terms of making sure that through artificial intelligence, when it comes to capital investment, for example, or even the revenues that come out of it, that there can be a solidarity levy that goes into supporting debt relief, or that goes into supporting social protection measures? Because when we talk about innovative financing, we have to look at all the areas where it is possible for countries to be able to generate resources from. But I just want to leave us with this in terms of the financing architecture, because it goes hand in hand with the global health architecture. It is also the representation when it comes to the governance. It is the representation in terms of who makes the rules, the representation in terms of who has access. And I think that's something that we must continue to advocate for. And for us as an organization, the issue of the debt crisis, sovereign debt crisis, is one that we're taking really seriously, because we cannot expect countries to find resources when they also have to think about paying creditors at exorbitant interest rates. So we must balance both. But parliamentarians also have a role to play in terms of the legislative oversight. We've talked about the Abuja 15% for so long. What are we doing to ring-fence health budgets to the point that parliamentarians should be able to say certain amount of the budget should go to health, whether it's for pandemics, whether it's for public health emergencies, and that should be ring-fenced. That is something that parliamentarians have the power to do. But beyond that is they also have the power to advocate, either through the International Parliamentary Union, the Unite, the different parliamentary forums that we have. We need parliamentarians to also advocate and lend their voices to the issue of the crushing debt crisis that we're seeing, whether it's in terms of the establishment of the Borrowers Forum or accelerating it, or whether it's in terms of, the debt pauses. We need to hear parliamentarian voices even more. And lastly, parliamentarians have constituents. And I think it's important that in terms of accountability, tracking and monitoring, even how debt is utilized, it is also thinking of how does this impact their constituencies as well? What are the implications at the grassroots level of this debt crisis? Because that helps us to generate the evidence. It helps us to argue the case, in terms of how we address debt, sovereign debt globally. And that's just adding that to what we need to think about if we think of equity and security.
Thank you, Kim. You've given parliamentarians a lot of homework that we have to take into consideration. And at the end of this session, before we close, I'm going to ask each of you in 30 seconds to just say what you think the role of parliamentarians should be. And so you can give it some thought. But in the meantime, while we still have some time, I'd like to open to the floor to ask if there are any questions you would like after this first round of interventions. If anyone would like to ask a question or raise an issue, we already have one at the back, please.
Yeah,
If you could present yourself and also.
Thanks so much. John Barrazzo, affiliated now only with George Washington University, where I teach part-time after seeing my global health career collapse last year. But I spent 26 years at USAID, the World Bank, and Save the Children, so I've seen global health from several different vantage points. And I'm curious to dive a little bit more into this issue of prioritization, because in the face of scarce resources, prioritization is absolutely critical. And yet, from what I've seen over many years, is that countries will prioritize very often, particularly if they're countries that are low-resource countries that are desperate to get to $60 per capita, funding. They will actually oftentimes do what is brought to the table. And so one of the concerns that I have in terms of the new U.S. government's compacts, that they're these bilateral MOUs, is that in fact they're bringing things to the table that don't necessarily are prioritizing some of the core issues. I think somebody mentioned MCH, maternal and child health, which I worked in for so long, family planning, basic preventive health care. And so the question is, how do we in fact work through this seemingly a bit broken, the system of civil society influencing parliament, influencing executive decision making, which in my view is broken in the US, because even though civil society has been successful in advocating for these core issues with the US Congress, the reality is that that's not being translated into programs in the executive branch, but I don't know if it's the same way everywhere in the world. So I'm just curious about some comments on this issue of prioritization.
All right, and I guess this is for everyone and not anyone in specific,
Correct.
right? All right. Before we answer, just asking because we won't have time for a second round of questions, so we have two people here.
Hi, my name is Adrienne Mendenhall with Pro Global Advisors, and just wondering how, before the pandemic, the global health world was very much focused on the Astana Declaration and investing more in primary health care. And maybe 1 to 2 years out or into the pandemic, really looking at investments in primary health care as very important to pandemic response, as we saw many case studies where either states or provinces within countries or even at the country level where there were strong primary healthcare systems, community-based healthcare systems, were better able to respond to the pandemic and conduct surveillance. Now that we're at this point in 2026, and as we look at the upending of the normal order for global health funding, how are these conversations around primary healthcare investments being represented, or how are they being discussed when many organizations and sectors of health are trying to essentially fight to just have enough to stay above water? How do we think about primary healthcare and those investments?
No, thank you so much. I'd please ask our speakers to take notes of the questions, and we're going to just ask Mary for a last question before we come back to the panel.
Thank you very much. I'm Mary Bussell with Trimar Strategies based in New York. And I think my question perhaps leads on from all of that. From what I understand around the room, most of us are focused on health and health issues. How do we change our dialogue, change the way we think to make our requests to governments, and particularly finance ministries, to invest more in health when we deal with different time frames from the finance ministries? I believe very strongly, and I've said for many years, health security is national security, which is global security. And picking up on some of the themes I heard from you, I'm shaking my head vigorously. Well, we need to change our language somehow to better align with the time frames within which we work versus governments, because they're based on the electoral cycle, and our cycle in health is very different.
Well, thank you. And the eternal question of how to convince leaders and investors to look down the road, and the political cycle limitation is a tremendous one to overcome. So we don't have much time, so I would suggest we do the following. A lot of questions. I'm not going to force anyone to answer. You take whatever you think is relevant from what you just heard from the floor. And if you could, well, I'll give about a minute each so we can end on time. And if you could end with the homework you'd like to give to parliamentarians of what you think they should be doing. Kemi, you've already started us off. And you can bring in your experience as a parliamentarian.
I have the homework at the end, so I'll comment on the homework.
So Sven, please, we'll follow the same order.
Okay, So, great question. What would I give as a homework to parliamentarians? First of all, I would give some homework to civil society. That means speak to us, talk to us. Don't simply be in your bubble, because that's something that I see more and more happening. All those debates need to happen on a much larger stage, and it's not by talking to each other that we advance the cause. I also think that the language we use actually matters. Whether it's speaking like a finance minister thinks, or whether it is how we advocate for certain things. I totally agree with many points that have been made as well on the debt service, and that's why the bank and the IMF has done a tremendous work on making sure to do wraparounds on refinancing existing loans, especially in health and educational sectors, by reducing the interest rates by up to 600 basis points, which is like more than halving the interest rates for certain loans. I just want to say that because it sounded a bit like, oh, there's nobody doing nothing. I want to say there are people doing stuff. The private sector could be doing a lot more. We need more cataclysmic capital being invested into healthcare, especially into primary healthcare, because the impact on GDP is tremendous. If you invest in primary community-based healthcare, give them, and it can be as easy as making every regional rural clinic, because it's not a hospital, capable of doing EKGs. It's very basic. It's very basic stuff. Those tools cost a few tens of dollars. If we make them available across the globe, we can reduce cardiac issues by a double-digit percentages. So the investment is immediately yielding results. So I think what I would give you as a homework as a civil society is talk to your elected leaders, talk to your parliamentarians, talk to your governments, but also use the same language they are using, because that's critical. If you don't understand their language, that's because we are not all technocrats. We are human beings after all, but we sometimes tend to be very narrow-minded on certain issues. So, and then the homework for parliamentarians I would take on is continue advocating for more spending, but that also means increasing the tax base in many countries. Because if we still have countries that are only generating 10% taxable taxes of their GDP, we don't need to be astonished that they're in a debt crisis. If you can't yield at least 15% of your GDP in taxable assets, you are in deep trouble. So that's something I also want to give to my colleagues from the developing countries, is either increase the taxes on the businesses that can pay taxes, or increase your tax base. Because if you are not working on your taxes, how do you expect to pay back anything? And then you will be dependent on that for a long time to continue. And that will actually hurt you in the long run, even at 2 or 3% interest rates. And just look at the US, what happens, because the US is now one of those countries spending more on that service than they are even spending on their military. And I think that's the biggest single budget position in the US. So even the US, I would now consider in that crisis if we are looking at international benchmarks.
Well, thanks, Sven. And I would also take that from your initial homework to civil society, that you as the leader of the parliamentary network of the IMF, World Bank, are willing to open doors to the 2,000 members of parliamentarians in committees around the world. Okay, so we have a bridge building exercise happening here. Priya, your thoughts?
Yeah, so maybe firstly, just picking up on some of the questions, I'd like to emphasize again that I think the point that you made there, that countries that had stronger primary healthcare systems were able to respond to the last pandemic more effectively, and we've also seen, COVID wasn't the first pandemic. We've had SARS, MERS, avian influenza, Ebola, Zika. But it's a question of within the primary healthcare system, what were the investments that they had, and if countries that had actually the capacity to do testing and diagnostics, that had community health workers that could, sort of go out and, create awareness and, mobilize people to go and get tested. That kind of investment in primary healthcare infrastructure in a disease agnostic manner, so that it wasn't just like one disease or another disease, but that there was a kind of a basic infrastructure that sort of enabled quick diagnostics, quick testing, those systems worked better, and there, countries didn't have to divert expenditures from maternal and child health and immunization and so on towards COVID, because they already had an infrastructure that allowed them to deal with the pandemic. It's countries where the primary healthcare system, didn't have, wasn't strong enough to detect, contain, etc., where expenditures had to be diverted, and then there was, there were lots of other fallouts of the pandemic. So, I think. And I do want to kind of emphasize that there is, my friend from the Global Fund, I think one of the things that we should acknowledge is that COVID, did teach us that somehow there was a gap in the multilateral health financing architecture. There was no one that had, invested in, these kinds of, kind of basic infrastructure. Those countries that had primary health infrastructure, I mean, they had done it, and of course, international aid is just part of the bigger sort of, architecture. But there wasn't a single dedicated institution that really reminded, Global Fund and, others in times of peace, please keep investing, Don't just invest when there's a crisis and then forget. So, if those investments are happening, I'm delighted. Because, I mean, that is the goal of what, that's the rationale for why we were set up, to help ensure that focus, to maintain that focus, that even in peacetime, please don't forget about these investments, because, the world has faced too many of these cycles of panic and neglect. And that's precisely why we're set up in a way that the Pandemic Fund doesn't actually make any direct investments. We use our grants to mobilize others, to get them to partner with us, and then make a collective investment in a country, so that the country isn't, being having to face 250 organizations knocking at their doors saying, we want to help you, we want this coordinated. I mean, I think Ethiopia has to deal with 250 organizations in health that kind of go and sort of say we can. So this is part of the problem in global health, has also been there's just been too much competition, too much overlap. I think we have to be disciplined, we have to work together, we have to make sure that our money, maximizes, the bang for each buck, particularly in this era of, constraints. Now, coming to parliamentarians and civil society, hold us accountable. This is taxpayers' money that, all of, at least the international funds, are based on. We would love to be invited to kind of tell you, how this money is being used. What are we doing? What are the results? What are the outcomes? What's the impact? That is the role of civil society. We really love the fact that we have 2 civil society seats on our board out of 21 seats. But that's just, those are our civil society representatives. But more broadly, we would love to be held accountable, because I think, that is what that's what's needed. So thanks.
Well, thank you, and that's such an important point, because accountability, of course, is critical when it's taxpayers' money, but it's also making sure building support for these mechanisms in the future. And we're happy to have the Pandemic Fund actually being accountable to parliamentarians at the Unite Summit happening in Manila next August. So, Rosemary, how do you see all of these questions from the floor and your homework for the MPs as civil society?
Yeah, I think just echoing the point around we need to invest, and invest within the global health architecture, the multilateral agencies. And then also to the point that once you invest in these funds or the global health institutions, there is, the investment prioritization starts from country level, which is what the good professor was talking about, like where is agenda setting happening, where is prioritization happening? And so one of the key things we'd like to see members of parliament partner with us in continuing to voice is to, in this global health architecture reform conversation that is happening, to take agenda setting back to the country level. And when it comes to the country level, again, it's just thinking about the national strategic plans, because that's where the agenda is set. It's thinking about the national health compacts, because that is where prioritization is set. But then even going a step further to say who is setting the agenda and where is that space? How is health governed at the country level? Are we seeing communities and civil society as part of the consultations in the lead up to the national strategic plans, in the compacts that we are discussing, whether it's the G2G MOUs, or even we know that with the World Bank and WHO, there is also the MOUs that a number of countries have been signing around UHC. So for all these compacts, where is that conversation happening and where is that prioritization happening? It needs to happen at country level, and at country level, we need to think about impacted communities at the table, civil society at the table. And then going to the primary health care components, it's the same thing for me in saying that we see stronger responses where primary health care is happening, and even stronger responses where primary health care integrates community systems. So community systems being part of the question, how do we get to the last mile? How do we get to the person who is not visible to the health system? How do we get to the person that is most likely to be missed by health systems? And that's where community systems strengthening comes in. The mother who is dying of preeclampsia or eclampsia that is not visible to health systems. It is really thinking about primary health care in terms of last mile, in terms of that community support. And the last thing for me is, we are saying, let's talk the language that decision makers are hearing, or understanding. So we are here at the spring meetings, and you'll hear a lot of conversations around job creation, strengthening economies. And I think it's important for us and members of parliament in those rooms to say that there is no way we are going to strengthen like job creation and our economies are going to thrive if people are not healthy. So human capital investments, health, education, nutrition, social protection, sexual and reproductive health and rights, and all those, like keeping people healthy is a starting point for creating jobs and for thriving economies. And I think then investing in that is going to be very useful in terms of even working with countries and supporting countries to create more jobs and to strengthen their economies. And for Africa especially, it's also investing in young people. We talk about the Africa Youth Demographic Dividend, which we will never realize unless our young people live to the fullest of their potential, where they are healthier and all their health needs are met. Yeah, thank you.
Well, thank you, Rosemary. And I keep being shocked many times through the Unite Parliamentarians Network, where many times we see that the first meeting some parliamentarians, even working in health, have with civil society representatives happens through engagements that we foster. And being the direct representatives of the people in democracies, it's quite shocking that there's a disconnect many times. And so hopefully, I think that's an important piece of homework that we all have to work better in that context. Mark, your final thoughts.
Thank you, and I want to thank the co-sponsors of this event, and particularly Unite. My last thoughts are inspired by the two first excellent questions from the audience. Let's look behind things that are said on a public rhetorical level, particularly in Trump administration policy. There are a couple of things that are said which are really positive, that there should be transition to country leadership. But what kind of country leadership? Does country include civil society, the whole of society, as Rosemary puts it, and is it sufficiently financed? And then secondly, on primary health care raises this point, the Trump administration is calling for all the countries that it is negotiating MOUs with to move towards integration. But the worst outcome of a move towards integration is sliding away from measurable advances on HIV, TB, and malaria toward moving towards 2030, and a very diffuse commitment to integration, but no accountability that one can watch. And so when I get to the homework for members of parliament, it's monitoring what gets spent. Is it serving primary health care needs? Is it also continuing to make progress rather than face resurgence on HIV, TB, and malaria? Sven asked civil society to press legislators. In the inverse, legislators need to look out for the central role of civil society as voice, as implementer, as part of responses. And then finally, go talk to your finance minister. Put pressure on the finance minister so that that chasm between health ministers and finance ministers is brought. This is a job not only for legislators in low and middle income countries, but it's the reason Friends has put out a report today that urges our own Congress to do oversight of the administration policy on transition. Thank you.
Thank you, Maria. It is a global effort, and thanks for that call to action also to parliamentarians. And Kemi, take us home then, please.
So I like the way Mark ended it, because when he said go talk to your finance ministers, because I'd written down here to say that when it comes to changing the narrative, I like that you raised that question, because oftentimes we look at health as charity, but it is not. It is an investment. And there are studies and research that tells us that $1 invested in health in a developing country yields $2 to $3 in return. And I think that's one of the things that we have to lead with. In terms of engaging ministers of finance, engaging ministers of health, getting them to talk to each other, and also engaging with civil society as well, or members of parliament. The framing of health needs to move from charity or, aid, or it needs to move to investment, because yes, it is directly connected to productivity. The more people are healthy, the more jobs that people can do, and the more money a government is able to make or to raise for its people. So it's connected to productivity, but it's also connected to security and stability. When people are healthy, you're also able to have stability. And I think we need to lead with that, and being able to provide the evidence that demonstrates that health is an investment, and one that should concern everyone, not just those in the health sector. Because even without health, you can't address issues of climate. Without health, you can't address anything else. So it stays, it's very key, and it's important that that framing is something that we continue to work with. And even when we engage communities or engage stakeholders, it is the fact that it's a key investment. It is tied to national security, regional security, global security. And that includes investments at every level, including regional investment, which is something that we are advocating for. It's the need for, investing in regional efforts, whether it's in manufacturing of medical countermeasures or financing, as you might want to call it. Now, for parliamentarians, I know I gave a lot of homework earlier, but I want to sum it nicely by saying we need reforms. Yes, a lot of work has been done, but more work still needs to be done, particularly when it comes to the global debt system. It is the reason why we have 3.3 billion people living in countries that spend more on debt servicing than they do on health or education. That is a problem, and that is something that parliamentarians working with civil society can help to advocate for. We need reforms, and we need it now. Thank you.
Well, thank you so much. That's your applause. Just to wrap it up then, we heard that more than half of the world population doesn't have access to the essential health services that people need. We hear that most countries are not on target to address their targets in terms of ODA, in terms of their international development funding. Only 4 countries are on target, according here to Sven. We heard how investing in health is the best way to prevent a crisis and to react to one. We also know, as was mentioned, how out-of-pocket spending is currently taking so many people into devastating financial crises within families, within communities. And we heard all of the challenges around, of course, the debt crisis, the lack of investment, the lack of leadership. I think also the important message of the disconnect that is growing between those making decisions and those representing the people on the ground. And so a lot of homework clearly has come out of this session for parliamentarians. We will continue this conversation at the Unite Global Summit in Manila on the 3rd to 4th of August. You're all invited so that we can make sure that the bridge between those legislating and those investing and those representing the people and their interests can all come together, so that at the time, so that in the near future we can actually make sure that despite the challenging moment we are living, we can continue to fight for a future where health for all can become a reality, as we like to say at Unite. Now more than ever, it's time to unite. Thank you so much.